Annual checkups will soon become a distant memory for many Ontarians. The province's physicians are moving towards, quote, personalized health reviews with limited examination and more discussion. And joining us now for more on the changes, Dr. Doug Weir. He's president of the Ontario Medical Association. And as I welcome you back to TVO, it's nice to see you again. We want to let everybody know that we want you to be part of this conversation. Producer Daniel Kitts is hosting a Twitter chat right now, so let us know your thoughts on moving away from annual physicals and whether you think patients in Ontario are overtreated or undertreated. And you can use the hashtag on Twitter, AgendaTVO. Okay, let's get into this. Docs across Ontario are telling their patients now, I gather, that they no longer need to come in for the annual physical exam. How come this is happening?
Well, as you may recall, we were in negotiations with the government in the fall, and part of that was when we came to the table, we wanted to make the healthcare system more efficient, and we brought in a number of ideas that we thought would do that. And one of them was to replace the annual physical with a personalized health review. The personalized health review is still an annual visit. It's for people between the ages of 18 and 64. For people on younger and older, nothing's changed. For people who have chronic illnesses, nothing's changed. But the evidence really shows that for healthy people in that age range, they don't need a full physical. And we've sort of known that for a long time, and there's an ever-growing accumulation of evidence around that. So we want to put that evidence into practice. And so what we want people to come in is we want them to come in still to see their doctor, but it'll be focused on what would be appropriate for that age and stage of their life. So for example, a young girl who comes in her early 20s, you're going to ask them a different set of questions that's going to have to do with lifestyle, what they're doing at that stage in their life. A 55-year-old woman who comes in, it's going to be about are they perimenopausal, and other kinds of questions about health risks that they might have.
If we've known for a long time that the annual health review or annual checkup as we knew it wasn't all that effective or helpful, how come we still did them?
Well, you know, I think doctors have been doing them for 100 years, and I think there's a certain kind of reassurance that patients have had by going in, and I think they think that by having that they're going to somehow be better off. I'm not sure that's the case, and I think that certainly is what the evidence is, that it's not the case. In fact, outcomes from the research show that whether you have an annual physical or not, it's roughly the same outcome. So but I think people still like the idea of going in, and so what we're really doing is changing it so that you still will see your physician, still get the kinds of evidence-based investigations that need to be done. For example, pap smears for women every 3 years, having your blood pressure checked. But it's not going to be this head-to-toe physical exam that really isn't useful. And I think, you know, change is always slow.
Let me just get a little greater clarity around how it's going to be different. I think right now you go in, they're going to take some blood, they're going to check your reflexes, check your blood pressure, check your heart rate, you know, how tall are you, how much do you know, everybody knows all of that stuff. What won't happen now going forward?
The biggest change is you're not going to get that head-to-toe physical exam. They're not going to necessarily check your reflexes unless there's some reason to think that you have a problem. They're not going to examine every sort of part of your body, and they're not going to do the same kind of extensive review of everything. What they are going to do is they're going to focus on the kinds of questions and counseling that would be appropriate for the kinds of risks that you'd be at if you were a smoker, for example, focusing on that, asking people about their drinking habits, their exercise, their diet, those kind of things.
I assume that the new personalized health review will cost the healthcare system less than the former.
That's right. The big change really is that physicians will get paid, instead of getting paid roughly $77, they're going to get paid $50. So that's where the savings come in. The hope is that because it's going to take less time, that physicians will have the time then to see more patients who are coming in with symptoms, so that it'll improve access for patients overall.
And I mean, I guess over 100,000 doctors, or how many docs are there in Ontario?
There's about 25,000 actively practicing physicians in the province.
And so multiply all of those changes, all of the difference in money by all of those doctors. How much money do you figure this will save over a year?
Well, I think the estimate is that it's going to save about $20 million. And that's because if you think about it, there's about 8,000 family doctors who practice comprehensive care medicine. So that's really the group that you're looking at.
And I mean, it's a $47 billion system, right? So is $20 million bucks real money in a $47 billion system?
Well, I think every dollar counts. And I think what it does is what it will do is, I don't know if it will necessarily save that money, because what it will do is it'll open up time for physicians to see other patients, and so they're going to bill for that. And so at the end of the day, on a per patient basis, it's going to save us money, but it will allow physicians to see more patients over the course of a year.
Let me read something that was on the CBC's website last month. Dr. Stephen Cudmore, family physician in Sudbury, said simply discussing a patient's health isn't effective. In the past, he said he's found underlying health problems even in seemingly healthy adults. We detected a couple of breast cancers that we treated successfully, he said. I would be a little worried to see what would have happened if they hadn't been in for their annual physical examinations. That's just one or two examples. There's more. The fear, I guess, is that by going to this new system, you'll miss things. Should we worry about that?
I would say no, because first of all, if you have a symptom, if you find something, you can still have access to your doctor, and you should really go in and see them right away. And the evidence really is that there is no evidence that at the outcomes of people who get a physical exam and those who don't is any different. If I can give you a good example, a good friend of mine went for his annual physical in June. 2 months later, he was having some back pain. It was a little unusual. They did some investigation. It turns out he had a tumor, and he started getting treatment for it. None of that was picked up at his annual physical, but he had a symptom 2 months later, and that's what brought him in. So it's probably true. Some things get picked up, but a lot of things that get picked up are things that would be picked up anyway because people are going to start noticing. People are going to start noticing they have a lump in their breast or something like that, and they're going to go in and see the doctor, and it'll get investigated and treated in a timely fashion. And the evidence is, in terms of outcome, and I think that's what we're most interested in, there's no difference. If we're going to keep the system sustainable, we have to base the billing on evidence. And that's what we're trying to do in this new agreement with the government.
Would the time spent with a patient for these personalized health reviews be more or less than what might have been spent during the annual checkup?
It'll be less time because if for no other reason, you're not going to be doing a full physical. You're going to be focusing on the things that matter at that person's stage and where they are in their life.
You'd like decisions, I presume, in the healthcare system to be made not for financial reasons, but rather for health of the patient reasons.
Right.
Could you, can you confidently tell people that, yes, this will save $20 million, but at the end of the day, that's not why the decision was made. This actually is about people's health first and foremost.
Yeah, well, I think we want to go on what's the best evidence, and the best evidence really is that there's no value to this. So I don't know if we want to be doing things that is not proven to be of some value. The other part is that if you do too many investigations, what you end up doing is you get a lot of false positives. In other words, a test comes back positive, but in fact you don't have some underlying condition, and then you have to get more tests. And so people assume that all of these investigations are sort of benign, but they're not, because they lead to further investigations, some of which can have their own consequences.
Isn't that your experience, that in fact you find more things that turn out to be nothing?
Oh, for sure. For example, a lot of screening tests are designed to pick up minor changes which then get further investigated before you find out that somebody has cancer or something like that. But the majority of people, oftentimes in these screening tests, in fact, only have mild abnormalities which are not, for example, cancer or something like that.
Well, that's the key. So let me just clarify in our last minute here before we get everybody else involved. The tests picked up more false positives, and these checkups ended up being less valuable than, say, the fears that we're going to miss things in the future.
That's right.
That's fair
exactly.
to say.
In other words, there's a risk and a benefit. Mm-hmm. The benefit, obviously, is you pick up serious illnesses and you start to treat it. The risk, on the other hand, is that you get people who get either they get anxious because they think they have something when they don't, or they have a test that was a screening test, which was positive, but in fact they don't have cancer, but they have to have additional tests to find out that they don't have cancer, and it's those additional tests that have their own risks associated with it.
Support Ontario's public television. Donate at tvo.org.